Hi there, my name is Eytan Stein. I'm the chief of the leukemia service at Memorial Sloan Kettering Cancer Center in New York City. And I'm excited to chat with you today about maintenance therapy for patients with acute myeloid leukemia who are not going on to receive an allogeneic stem cell transplant. I think one question that really comes up is just fundamentally, what is maintenance therapy? And the way I think about maintenance therapy is it is therapy that is typically given after induction and consolidation chemotherapy to help prevent patients from relapsing and thereby extending their overall survival. What I'm not talking about during this little discussion are patients who are getting lower intensity therapies, such as azacitidine with venetoclax and azacitidine with ivosidenib, where those patients, although they may continue on the aza-ven or the aza-ivo for a prolonged period of time, and that is sometimes called maintenance, I think that's sort of a different discussion, so I'm not going to address that today. I'm really going to talk about the patient with acute myeloid leukemia who comes in and gets induction chemotherapy, typically with an agent like 7+3, or another intensive chemotherapeutic approach. That patient goes into remission and then receives consolidation chemotherapy with more high-dose treatment. And then the question becomes, well, this patient is, for whatever reason, not going on to an allogeneic stem cell transplant. Is there something that can be done to help prevent relapse? So the best data for using maintenance therapy in patients who have received intensive induction chemotherapy followed by consolidation, or even not followed by consolidation, are based on the results of the QUAZAR study. The QUAZAR study was a large randomized placebo-controlled phase 3 study where patients were randomized to receive oral azacitidine, known as CC486, for maintenance therapy, and compared to a group of patients who received matched placebo for maintenance therapy. And in those patients who received oral azacitidine, they had a median overall survival that was 10 months better than the patients who received placebo. Now, it's really important to think about the group of patients that were treated as part of this study. This study enrolled patients older than the age of 55 who had received intensive induction chemotherapy with intermediate or unfavorable risk cytogenetics, and then did not go on to receive an allogeneic stem cell transplant. So really in 2024, that group of patients isn't so big because many of the patients with intermediate or adverse risk cytogenetics will go on to receive an allogeneic stem cell transplant. But if there is some reason that your patient cannot receive an allogeneic stem cell transplant, and I've had a number of patients like this, I do place them on oral azacitidine. The oral azacitidine is given 14 days on and 14 days off in repeated cycles of 28 days each. The major side effect of this drug is myelosuppression, so neutropenia and thrombocytopenia, as well as some nausea, which is typically well controlled with medications such as ondansetron and other oral antiemetics. What's also interesting about oral azacitidine in the maintenance setting is that this compound seems to improve the overall survival in no matter what subgroup you look at. So whether you look at a subgroup of patients who were MRD positive after induction and consolidation, whether you look at a group of patients who had only received induction and then went on to receive maintenance therapy with oral azacitidine, or had only received 1 or 2 cycles of consolidation and had not completed their consolidation with oral azacitidine. And very practically, where I've used this drug most frequently in patients with intermediate or unfavorable risk disease are for patients that something happens to them during the induction or consolidation that precludes them getting an allogeneic stem cell transplant. I recently had a relatively young patient with acute myeloid leukemia who received induction and consolidation, 1 cycle of consolidation, and post-consolidation he developed heart failure with an ejection fraction of 25 to 30%. And that patient, because of the heart failure, was not a candidate for an allogeneic stem cell transplant. And that is a patient that I gave oral azacitidine to as maintenance therapy. There are other maintenance therapies that can be considered, specifically in those patients with FLT3 mutant acute myeloid leukemia. So there have been two big randomized phase 3 studies combining FLT3 inhibitors with intensive chemotherapy for newly diagnosed FLT3 mutant AML. One of them combines a drug called midostaurin with 7 and 3. The other combines a drug called quizartinib with 7+3. Both of those studies had a maintenance component to the study, although it was not randomized. So they were single arm components or single arm studies that were part of the larger study. But I have been using maintenance midostaurin or maintenance quizartinib in those patients with newly diagnosed FLT3 mutant acute myeloid leukemia who receive induction and consolidation and for whatever reason are not going on to receive maintenance therapy or receive an allogeneic stem cell transplant. Of note, gilteritinib, which is a third FLT3 inhibitor, has not been studied in the group of patients who receive induction and consolidation in a large study as maintenance therapy. It has been studied after an allogeneic stem cell transplant. It has not really been studied in patients who have not received an allogeneic stem cell transplant. And I guess the last point I'll make here is that we do all want our patients not to relapse. And I do think that the rationale for maintenance therapy is obviously very strong. We're hoping that there are other targeted therapies that may be coming towards FDA approval where we'll be able to see a benefit for using maintenance therapy. One thing that I'm thinking about is a group of drugs called menin inhibitors, which seem to be very active in patients with NPM1-mutant acute myeloid leukemia and in patients with KMT2A-rearranged acute myeloid leukemia. And there will be studies that will be looking at the utility of maintenance therapy in those patient populations, even in those patients who don't receive an allogeneic stem cell transplant. Okay, one more thing to say, and then that's really my last thing. I do think that you have to be wary about applying maintenance therapy everywhere. And specifically, you have to be wary about applying maintenance therapy to patients with favorable risk acute myeloid leukemia. So the group of patients with favorable risk AML, specifically those patients with core binding factor acute myeloid leukemias, while some have advocated, I recently saw a publication where some have advocated for using oral azacitidine in that patient population, where those patients typically don't go on to receive an allogeneic stem cell transplant in first remission, what you run the risk of is overtreatment. So you run the risk of giving someone maintenance therapy when maybe they've been cured from the get-go and they never needed maintenance therapy in the first place. And one good way with favorable risk acute myeloid leukemia to kind of sort out how your patient might end up doing is to monitor MRD by a very sensitive RT-PCR test, which are commercially available. Typically, if the patient has MRD positive, those patients go on to receive an allogeneic stem cell transplant. But I guess I want to reiterate that I would be wary about applying maintenance sort of willy-nilly in favorable risk acute myeloid leukemia, where you might be overtreating a large group of patients who may actually already be cured. Thanks for your attention.